Thank you for joining us for AAKP's 45th annual patient meeting. I'm Ed Hickey. I'm an attorney and United States Marine Corps veteran, and am honored to serve as AAKP's newly elected Vice President and as a member of AAKP's Board of Directors. I'm also chair of AAKP's Veterans Health Initiative, a responsibility I will keep as AAKP's Vice President. I've held positions in the federal government over the past few decades, including service under several presidential administrations, and am now in private practice. I've managed kidney disease for 5 years as a chronic kidney disease patient and also as a caregiver. Veterans and their families face many unique challenges related to managing their health care, and this is especially true for veterans who suffer from kidney and other complex chronic diseases. I'm committed to making certain that my fellow veterans have their voice heard, retain access to care they have earned and are legally entitled to at the VA and elsewhere, and gain the benefit of new research and innovation in the realm of biologic diagnostics and devices. It's an honor to serve alongside AAKP staff and fellow board members as we ensure that kidney patients across the globe are getting the best kidney care possible, whatever the stage of our disease. AAKP knows that innovation in kidney medicine is fueled by intellectual curiosity, courage, and noble instincts of researchers, entrepreneurs, and investors. It also depends upon laws, regulations, and payment systems that are prepared by informed policymakers who are committed to solving life-threatening issues kidney patients manage every day. AAKP also knows that in order for innovative concepts to find their way to the marketplace, it will take the organized and loud voice of patient consumers like us who demand changes to the status quo. AAKP is intent on organizing that voice here in America and globally during this decade of the kidney. We fully intend to build a groundswell of patient voices to support a consortium dedicated to developing solutions for patients, including new biologics, diagnostics, and devices like the artificial implantable kidney. Over the past 6 months, AAKP has produced 3 national and international virtual events covering issues related to COVID-19, research in clinical trials, means of correcting disparities in clinical trials, and as well as new innovations in kidney drugs, biologics, and devices. Across these 3 major events, AAKP viewing audiences span more than 70 countries and combined involved over 75 global and national experts, 40 American and global patient experts, and over 100 current and emerging topics. AAKP has broken all historic metrics for engagement with these events, and our global summit alone will exceed a viewership of over 20,000 people, nearly double the number of the 2019 inaugural summit, while reaching 50 countries. AAKP has also produced over 10 webinars within our COVID-19 Healthline series on topics including return to school, VA kidney programs response, mental health management, and updates by our strategic partners at the Center for Disease Control and Prevention. These webinars involved over 14 experts and 24 patient experts. The total audience engagement of these events to date, excluding the annual patient meeting, now exceeds over 50,000 people. This number will continue to grow each day in the midst of a continuing COVID-19 crisis, and as our content continues to be shared globally across multiple platforms. AAKP plans to put the broad new kidney audiences we have reached out and our countless new AAKP members we have gained firmly behind those driving innovation in kidney disease medicine. Our panel today is titled Innovations to Diagnosis and Disrupt Disease Progression. I'm pleased to introduce our first panelist, Dr. Donald E. Wesson. Dr. Wesson?
I'm Dr. Don Wesson, president of Donald E. Wesson Consulting, LLC, and professor of medicine at Texas A&M College of Medicine in Dallas, Texas. I'm delighted to share with you my insights about this common complication of chronic kidney disease, chronic metabolic acidosis. Chronic metabolic acidosis and chronic kidney disease is common, harmful, and needs to be treated, and is somewhat distinctive amongst the complications of chronic kidney disease in that it is not just a complication of chronic kidney disease, it is also a cause of progression of chronic kidney disease. So in this slide, let's talk about chronic kidney disease, or CKD, overall. Let's begin with the top portion of the slide that tells us that CKD is characterized by a gradual loss of kidney function over time, and that is measured in years. The left side of the slide tells us that more than 37 million, or about 15% of the US population, has CKD. The bottom part of the slide tells us that CKD is the 9th leading cause of death in the US. And in addition to that, CKD increases the risk of getting other chronic diseases that cause death, like heart disease and stroke. The right part of the slide tells us that CKD is a very expensive chronic disease to manage, consuming about $114 billion in Medicare costs. Chronic metabolic acidosis is a buildup of acid in the blood. This acid is generated through our normal metabolic processes, that is the way the body machinery works, and also by the food that we take in. That combination of contributors to acid production by the body leads to the need for that acid to be excreted or removed from the body. Normally functioning kidneys are able to completely excrete or remove from the body that total amount of acid that is made over the course of a day. However, as kidney function declines with time, the kidneys are less able to completely remove that acid, and some of it accumulates. As kidney function gets worse, that accumulation or buildup gets worse. And that built up acid titrates or reduces the level of the main base in the blood, that is bicarbonate. And so that we can recognize the presence of chronic metabolic acidosis by a decrease in the blood bicarbonate concentration. The more acid that has built up, the lower the blood bicarbonate concentration. So that blood bicarbonate concentration allows us to detect the presence of metabolic acidosis, and it also is a guide to how well our treatment is in treating metabolic acidosis, because when we treat metabolic acidosis, we look for that blood bicarbonate concentration to increase with time. So I've just told you that chronic metabolic acidosis is indicated by a reduction in the blood bicarbonate concentration. It is defined by that blood bicarbonate concentration being less than 22 milliequivalents per liter. It is quite unusual for chronic metabolic acidosis in CKD to have a serum bicarbonate concentration less than 12 milliequivalents per liter. So the typical range of chronic metabolic acidosis by blood bicarbonate concentration is between 12 and 22 milliequivalents per liter. We've already learned that more than 37 million Americans have CKD, and that's indicated in that maroon bar on the left. Of those 37 million, the gray bar on the right shows us that about 3 million of those individuals have chronic metabolic acidosis, So it is a common complication of CKD. When we talk about the harm that chronic metabolic acidosis can cause, we're talking three major organ systems: bones at the top, muscles in the middle, and the kidneys at the bottom. When this acid builds up in the blood, one way that the body deals with that is by so-called buffering it. That is, it binds the acid and keeps it from interacting with tissues and causing harm. The biggest source of buffer that we have in the body are the bones. These bones bind acid, buffer it, and keep it from causing injury to other tissues. That's the good news. The bad news is that over time, this buffered acid reduces the mineral content of bones, making the bones weaker and increasing the risk for fracture. The middle part of the slide reminds us that this buildup of acid decreases muscle size and its strength. And we're going to talk about how important that is going forward. Lastly, this accumulating or building up of acid hurts kidney tissue, and that means that this chronic metabolic acidosis can reduce kidney function over time. That is, it can make CKD worse with time. So recognizing that this buildup of acid is indeed harmful, as we've discussed, the international organization, that is KDIGO, and the national organization with the National Kidney Foundation, both recommend treatment of chronic metabolic acidosis, and they recommended that treatment be initiated when the blood bicarbonate concentration is less than 22 milliequivalents per liter. And one of the reasons to treat it is to slow the progression or the worsening of chronic kidney disease that is caused by chronic metabolic acidosis. So recognizing that chronic metabolic acidosis causes harm, let's look at how often it is treated. And when you do that, you recognize that it is an undertreated complication of chronic kidney disease. This slide depicts the outcome of querying two large patient databases and patients with chronic kidney disease and asking the question, of those who meet the criteria for treatment of chronic metabolic acidosis, what percentage of those patients are actually being treated? These two large databases show that 2.7% on the right part of the slide and 15% of patients in these respective databases were actually being treated, showing that chronic metabolic acidosis is severely undertreated. There are a number of reasons for that, and some of which we will get into in the next slide, which talks about the challenges that relate to our current treatment strategies for chronic metabolic acidosis. So why would chronic metabolic acidosis be undertreated? Let's look at two studies that can give us an insight into that. So recognizing that chronic metabolic acidosis is a buildup of acid in the blood, the two major strategies we have to treat it is reducing acid intake or balancing or neutralizing that acid with oral alkali. So let's talk about reducing acid intake. That is done with diet. Remember I told you that part of the production of acid in the body comes from diet. Proteins, particularly animal-based proteins, when metabolized by the body, yield acid, and many plant-based foods like fruits and vegetables, when they metabolize, they yield base. And so one can reduce the amount of acid from the diet by lowering the amount of animal-based protein and increasing fruits and vegetables. Although these diets can be shown to work, they are very difficult for patients to maintain and sustain with time, as we'll see in subsequent slides. The second way is by neutralizing or balancing that buildup of acid with alkali, like sodium bicarbonate, that is taken into the systemic circulation, and it balances or neutralizes that acid. Multiple pills of this sodium bicarbonate has to be taken with time. Those pills are not very palatable, and they provide a sodium load that can be problematic, as we'll see going forward. So this is a slide that looks at reducing acid intake with diet. That is one of the largest studies that has done that. About 200 patients that were received, on the left part of the slide, a very low protein diet that has low animal products and a lot of fruits and vegetables, versus a traditional low protein diet, which reduces the amount of protein being taken in, but that protein is animal-based protein. Again, focusing on the left part of the slide, the diet that has mostly fruits and vegetables and no animal products in it, those patients had a significantly higher increase in their blood bicarbonate compared to the individuals who were on the low protein diet. If we move to the right part of the slide and we look at that maroon bar of the patients who have the low animal products but high fruits and vegetable diet, compared to the patients in the red box who had only the reduced protein, but it was animal-based protein, these bars tell us the percentage of patients who had a slowing of the decline of their kidney function with time. Those who had the low animal product protein diet with high fruits and vegetables had a slower decline of their kidney function with time, showing the effectiveness of this reduced acid diet. The downside, however, is that only 15% of the patients who were recruited for this study could maintain and sustain the diet with time. This slide looks at the second way by which we have to treat chronic metabolic acidosis today, that is by oral base or sodium bicarbonate or alkali that can neutralize the acid. The left part of the slide looks at a study of over 300 patients who received the sodium bicarbonate tablets in the maroon bar, or just received the standard CKD care without these sodium bicarbonate tablets. This study showed that those taking sodium bicarbonate had a significantly higher increase in their blood bicarbonate concentration than those in the red bar who did not. If we move to the right part of the slide to look at the effect on the slowing of kidney function decline, the maroon bar of the individuals who took the sodium bicarbonate tablets shows a slower worsening of their kidney function compared to the patients represented in the red bar who did not take sodium bicarbonate. One of the downsides, despite the effectiveness of sodium bicarbonate in slowing the decline of kidney function in these patients, is that the effective dose added 1 gram of sodium to their diet. And we recognize that one of the effective ways by which we treat individuals with chronic kidney disease is by restricting sodium in the diet. So this benefit of slowing worsening of the progression of chronic kidney disease came at the cost of a higher dietary sodium. And the importance of this restriction of dietary sodium is shown on this slide, that gives recommendations of these important organizations that oversee the management of chronic disease that are listed on this slide, all of which recommend restricting the amount of sodium in the diet, including in chronic kidney disease. So if we focus on the box at the top left that looks at chronic kidney disease, the recommendation is that such patients take in less than 2 grams of sodium per day. I've already told you in the study that was on the previous slide, the successful dose of sodium bicarbonate that slowed kidney function, unfortunately, was associated with an added 1 gram of sodium to their diets. And so that has already included half of the allowable sodium in patients who have chronic kidney disease. That being a challenge with using sodium bicarbonate to treat chronic metabolic acidosis. So in summary, I want you to remember that chronic metabolic acidosis is common in patients with chronic kidney disease. Studies have shown, some of which we've mentioned, that treatment of chronic metabolic acidosis and CKD can slow kidney function decline. Nevertheless, there remain important challenges in the management of chronic metabolic acidosis and CKD. I really appreciate the opportunity to spend this time with you to talk about chronic metabolic acidosis and CKD. Thank you for the opportunity to do so, and we have the opportunity to address some questions if there are any.
Thank you, Dr. Wesson, for that wonderful presentation. I've got a couple questions for you. First, as a patient, I've not heard much about this issue, but found your presentation quite interesting. Often I do not feel well. What signs should I look for that may be related to this condition, and how do I ask my doctor to check for this?
Well, first of all, thank you for that good question. It's certainly not surprising that you have not heard about chronic metabolic acidosis in CKD, because it's only been in recent years that scientists have recognized the harm that comes from chronic metabolic acidosis. One of the things that we've just talked about is the harm that it can cause bones and muscles. And that combination can reduce our physical activity and can limit our ability to do certain things like climbing stairs or lifting groceries. And so if you have CKD and you're recognizing a gradual limitation in your physical activity, I encourage you to talk to your doctor about it, because she or he can do tests in the office that are relatively simple and that can measure the level of your physical activity, and then intervene with ways by which they may be made better, and measure it to follow that progress with time.
Thank you, Dr. Wesson. One last question. I was recently diagnosed with chronic kidney disease, and looking at this particular condition, are you optimistic that innovation is on the way to help me manage this condition? Are there more resources coming to help people like me delay the progression of my disease?
Well, thank you again for that question. This is an exciting time in scientists exploring many aspects of chronic kidney disease, very importantly, ways by which treatments can slow its progression and improve kidney health. And as we've talked about, metabolic acidosis can worsen kidney health with time, and its treatment can make kidney health better, specifically slow its progression over time. As we speak, there are treatments being tested for chronic metabolic acidosis that I'm hopeful will add to the options that we currently have to treat metabolic acidosis, and that those additional options will improve the treatment of chronic metabolic acidosis and hopefully slow its progression and reduce the need for dialysis or a kidney transplant in our patients who have CKD.
Thank you very much, Dr. Wesson. Our next panelist is Peter Maag, Chairman and CEO of CareDx. Peter?
Hello, my name is Peter Maag. I'm the Chairman and CEO here at CareDx. I'm very excited to be talking to you today about innovation to diagnosis and disrupting disease progression. Thank you very much for the leadership of AAKP for having us today at this meeting. We at CareDx are entirely focused on transplantation. Transplantation is all what we do. As you can see here on the slide, not only do you see the transplant recipient, but also the transplant organ donor, as well as the primary caregiver. This picture really exemplifies what we do at CareDx. We focus on the entire transplant ecosystem. We here at CareDx come to work every day to focus on transplantation, and COVID-19 has put a bit of an extra challenge on us, but we come to work every day focusing on transplant patients. So hoping that we can bring our latest innovations, our latest solutions, and our services to you, the transplant community. Now, who are we at CareDx? We have 20 years of dedication partnering with the transplant community and everybody that is working in this very exciting field of science. We want to be a sustainable company. While we are only 450, 500 people, we are entirely focused on making sure that we also build an organization that is lasting for many years to come. We are leaders in science and technology in transplant diagnostics. We are applying latest technology to this field, making sure that we can match organs to recipients, but also care for patients once they have received this life-saving treatment. We are first to bring donor-derived cell-free DNA to this space, and also gene expression profiling, making that available to the community, which is the latest technology in diagnostics. We are entirely focused on our mission, on patients, and increasing long-term patient outcomes. I'll share with you in this upcoming presentation a little bit how we are going to do that. We are committed to innovation, so this is about this talk about how can we continuously innovate, making sure that these innovations actually arrive at patients. What you can see here at this slide, that we have multiple touch points at CareDx along this transplant patient journey. We are helping transplant centers to manage the wait list. We are matching organs to recipients with our latest technology. And then after transplantation, we focus on liquid biopsies. With our technology, we have blood-based tests that are almost as good as biopsies, or in many times maybe superior, because you can do them more often. And then we have augmented intelligence solutions, so latest innovations on making sure that we have risk prediction scores. We can tell you how long these organs most likely are going to help you in the future and how long these organs will stay healthy. We are managing electronic medical records. Data is so important in this field, so CareDx is going to create a smart electronic medical record where this electronic medical record is actually working for the doctor and not the doctor is working for the electronic medical record. And then we're also heavily engaged in quality management. Quality is so important, not only in the transplant setting, but overall in healthcare. So CareDx is having a quality management tool and actually works with many transplant centers around the country, making sure that we have a very strong quality focus. CareDx is really the leading partner in transplantation. We are already managing today more than 25,000 patients on our platforms. More than 180 transplant centers have adopted our technologies, not only in lung transplantation, in heart transplantation, but of course also, which is most important for this talk, for kidney transplantation. So very strong dedication to the kidney transplant community. We at CareDx believe very much in if there's better data and patient engagement, that will ultimately lead to better long-term outcomes. We have novel surveillance solutions. We are focusing on driving patient engagement, making sure that the patient is engaged in the healthcare decision-making, and then is also heavily taking control over their long-term outcomes, understanding where he is or she is on that patient journey. So how do we do that? How do we focus on long-term outcomes? There are really three elements in our strategy on making sure that we are increasing the life of this transplanted organ. On the one hand, immune modulation is incredibly important in that journey. The second is compliance and adherence, making sure that you stick to your protocols or that patients have access to a follow-up that allows them to be adherent to their medication profiles, for example. And then thirdly, it's also very important that we standardize and then individualize our approaches. What do we mean with this? Very often we see the 250 transplant centers in the country reinventing the wheel, having different approaches to the patient care. If we can standardize, that will allow us to spend more time on the individual patient rather than reinventing the wheel all the time. So making sure that we spend more time on the individual patients will allow us to increase long-term patient outcomes. When better data and better engagement leads to better outcomes, we also need to have better tools. With our surveillance blood tests, AlloSure and AlloMap, which are latest technology innovations in the field of transplantation, we are making sure that we have better data, and with better patient engagement, we are actually improving long-term graft survival. We are incredibly excited about bringing these novel solutions to the transplant community. What is so special about AlloSure? AlloSure is a non-invasive tool that's entirely based on a simple blood draw. You don't need a biopsy in many cases. You don't need having these serum creatinines drawn, which are very often ambiguous in terms of, do they really inform you about the level of risk that you have or about the health of the organ? So serum creatinine might be less accurate, and biopsies are definitely more invasive. What would you rather have, a biopsy or a simple blood draw? So AlloSure is really a non-invasive solution to keep on doing monitoring of your health of the transplanted organ. So how does AlloSure actually work? AlloSure is detecting traces of the organ DNA in the bloodstream of the recipient. Our technology is detecting these little pieces of the organ that are traceable in the blood. And these little traces are informing about the health of the organ. So our technology helps us to identify if there's cell turnover more rapidly in the transplanted organ. And this cell turnover can be indicative of the health of the organ. And so our simple blood test is detecting the health of the organ. Having great technology is fantastic, but you also have to have the right service model. And getting a simple blood draw sometimes is not so easy, especially under COVID time. So we have innovated also on our service offering, making sure that we now offer mobile phlebotomy blood draws. What does RemoTrack do? This is our mobile phlebotomy solution here at CareDx. We actually have a phlebotomist sent to the home of the patient, getting the blood work done by a simple blood draw, making sure that the results of all these diagnostics come back to the transplant center, come back to the caregiver, making sure that they have all the information they need in order to determine, is it important for the patient to come into the transplant center or the practice? Or can we do a simple telehealth visit? Or maybe just do a simple phone call by making sure that everything is okay. So RemoTrack is a very latest innovation for us, making sure that we have a service model that cares for all transplant patients. But let me come back to better data and engagement leads to better outcomes. Now with AlloCare, our patient app, we're innovating once again at CareDx in this space. This is a latest contribution where we are driving patient engagement so they can have more say in this healthcare decision-making process. We are launching this AlloCare app as a patient engagement tool. This patient engagement tool will allow us to remember appointments, track and monitor medication adherence, measure health activities, and maybe also helps us to build a stronger tie into the transplant community as patients are wanting to connect and exchange information, maybe about their health status, but also about the latest news that they have read. So building this community on the palm of your hand is going to be incredibly exciting with AlloCare. Now we are connecting a lot of information, not only the patient information that you have with your mobile app, but also the electronic medical record information that the transplant center has. In an ideal world, all that information comes together at the point of decision making with the transplant caregiver, so that your doctor or your nurse has, at the time of seeing you, all the information available to make a better decision. And now if we have smart algorithms that are supporting her or him, it will be an even better outcome in the future because he has all the information available at the right time. So this is going to be a challenge for us in the future, which we're ready to embrace and ready to innovate around at CareDx. Now, after all this great innovation, I also wanted to point out that there are a number of other presentations in this series that are worthwhile and that are managed with CareDx's support. So tips for post-kidney transplant care with Ashley Pierce, Patrick G., and Derek Forfang. A shout out to the three of them. Make sure that you are visiting their presentation as well. And then one very special shout out on Saturday, September 26, 2020. We'll be launching our AlloCare app at the AlloCare Transplant Festival. We will have sports celebrities and many others are joining us for an incredible transplant festival. So please mark your calendars for September 26, 2020. I'm very much looking forward to see you there. At caredx.com/transplant festival, you can sign up for this very exciting event. Thank you very much for your attention. We at CareDx are focused on transplantation and transplant care. For all these transplant patients among you, make sure that you come and visit us on caredx.com. Love to get your feedback and love to get your engagement. Thank you very much.
Thank you very much, Peter, for that presentation. I've got a couple questions for you as well. As AAKP has designated 2020 as the start of the decade of the kidney, an era in which there will be many breakthrough innovations for detecting, treating kidney disease. As a visionary, what would you like to see happen in the next 10 years for patients?
Well, I would just congratulate AAKP of having that dedication to kidney disease. It's incredible to see the community coming together and making so much focus on this very, very important area of healthcare. What I'd like to see in the next era is a significant shift away from dialysis into transplantation. CareDx is all about transplantation and transplantation medicine because we think that it is a significant improvement for quality of life and has a potential to have so much better outcomes on the long term for the patient. So I would love a lot more focus on shifting patients that are currently on dialysis and allowing them to have access to transplantation because it will improve their quality of life so tremendously. And with that, at CareDx, we're completely dedicated on making that happen.
Thank you, Peter. One last question. As a business leader, can you tell me what the greatest barriers are for you to bring new products in the market and how patient advocates like AAKP can provide greater assistance to all entrepreneurs?
Thank you so much. That's an excellent question. You know, it keeps me up at night. I think there are really two answers to this. On the one hand, it's incentives. On the other hand, it is information. Let's make sure that there are the right incentives to continuously innovate in healthcare. Let's make sure that we allow patients to shift away from dialysis and have them move into transplantation with the right incentive structures for the dialysis clinics, for the transplant centers, but also for the community nephrologists. So let's make sure that we have the right incentives. But secondly, it is also about information. Let's make sure that patients have access to the right information, that clinicians and caregivers have access to the right information, making sure that we are having the right information at the right decision point. And having smart electronic medical records, having patient engagements, maybe with a mobile app like AlloCare from us, having that level of information will drive better outcomes in the future. AAKP has been a phenomenal partner in this, and especially on the dissemination of information is doing a fantastic job. So let's keep up the good work at AAKP, and we at CareDx will continue to drive forward to drive innovation in the field. Thank you.
Thank you very much, Peter. Our next panelist is Dr. Christopher Collins, Medical Director of Aurinia Pharmaceuticals. Dr. Collins?
Hi, my name is Chris Collins, and I'm one of the medical directors at Aurinia Pharmaceuticals. Thank you for the opportunity to speak to you today about lupus nephritis. Aurinia is a late-stage clinical biopharmaceutical company focused on developing therapies in disease areas that have been historically challenging to address, like lupus nephritis. As you can see on this timeline, the corporation was initially known as Isotechnica Pharma and was founded in Victoria, British Columbia in 1993. 20 years later, it merged with Aurinia and subsequently focused on developing a compound for lupus nephritis. And this year, we submitted our compound to the FDA for approval. Around the same time, Aurinia opened its principal commercial hub in Rockville, Maryland, just outside of Washington, D.C. Before I talk specifically about lupus nephritis, let me first give you a little background about systemic lupus erythematosus, or SLE as it is commonly referred to. SLE is a chronic, very complex, and often disabling autoimmune disease. Like in other autoimmune diseases, in lupus, antibodies target the tissues of a person's body, resulting in inflammation and damage. With lupus, however, there can be a wide range of affected organ and tissue systems, including the kidney. Overall, it occurs in approximately 1 in every 1,000 people, and currently there are an estimated 320,000 people in the US with SLE, mostly women. Lupus nephritis, or LN as will commonly be referred to in this presentation, is one of the most common severe manifestations in patients with lupus. According to multiple different epidemiologic studies, LN can occur in upwards of 50% of individuals diagnosed with lupus. There is significant variability in the manifestations of LN, which can vary from asymptomatic with minimal activity to a high degree of inflammation and overt nephrotic syndrome, which is defined as the clinical symptoms associated with high volume protein loss in the urine, like leg edema, and even renal failure. There are also a number of different risk factors that can influence which patients are more likely to develop lupus nephritis. Such risk factors include a new diagnosis of lupus at a younger age, male gender, and Asian, Black, and Hispanic populations, which I'll discuss more about in the next slide. In the United States, lupus nephritis is indeed more common in non-white populations. Rates of LN vary considerably in patients with SLE when stratified by race and ethnicity. Asian, Black, and Hispanic people have much higher rates of lupus nephritis compared to white people, as depicted in this graph here. Additionally, Black and Hispanic people tend to present with more severe subtypes of LN, higher serum creatinine levels, and more proteinuria. It is estimated that approximately 10 to 30% of patients with lupus nephritis will eventually progress to end-stage renal disease within 15 years of their diagnosis. Risk factors that predict progression to end-stage renal disease include the same races and ethnicities as discussed previously, elevated serum creatinine levels at time of diagnosis, nephrotic range proteinuria defined as 3 or more grams of protein in the urine per day, a younger age, and histopathologic evidence of more aggressive LN subtypes. A nephron is one of the functional units of a kidney that filters blood, selectively reabsorbs substances such as glucose and amino acids, and excretes nitrogenous waste such as urea and excess water and salts in the form of urine. Collectively, they are critical in maintaining normal kidney function. In lupus nephritis, episodes of inflammation or LN flares can result in irreversible damage to these structures. Data suggests that even a single episode of lupus nephritis can lead to irreversible nephron loss, potentially shortening the lifespan of the kidney by decades. As shown in this graph, gradual nephron loss occurs with normal aging, as depicted by the top line. However, with just a single episode of lupus nephritis, patients end up with significant renal impairment. If management of the LN episode is successful, they'll resume normal age-related pattern, as shown by the purple line. However, if the inflammation of LN continues unabated, eventually patients end up with premature renal failure. These observations are important as clinicians believe that earlier detection and intervention of lupus nephritis can minimize the impact on nephron loss. It is without question that lupus nephritis is bad, especially when it results in renal damage or kidney failure. And despite decades of research and use of different therapeutic approaches, an unacceptable number of LN patients end up with end-stage renal disease. Observation studies of patients with lupus nephritis, including those who will go on to develop end-stage renal disease, demonstrate that these individuals have a significant higher mortality than the general population. Looking at this chart, you can see that lupus patients with renal damage have an estimated 14-fold increased risk of premature mortality relative to the normal healthy population. And lupus patients with end-stage renal disease have a greater than 60-fold increased risk of early death. Indeed, as illustrated in the table shown here, mortality due to lupus nephritis is greatest in the Black population, with a 27% increased risk of premature death compared to white patients with LN. The reasons for this discrepancy are mostly unknown, but are likely contributed by a combination of genetics, as well as socioeconomic status and access to healthcare. The reasons for premature mortality seen in lupus nephritis patients is complex, but one measurable cause of death is cardiovascular events. As shown on the graph on the left, lupus patients with LN have over an 8-fold increased risk of myocardial infarction or heart attack relative to lupus patients without LN, and an 18-fold increased risk of myocardial infarction relative to healthy individuals. When looking at mortality due to cardiovascular events, as shown on the right, lupus patients with nephritis are over 4 times more likely to die from one of those events when compared to non-LN SLE patients, and almost 8 times more likely to die relative to healthy controls. In this study, as well as similar disease outcome data, this illustrates the significant clinical impact that lupus nephritis has on patients. Next, I'll spend just a few moments discussing the diagnosis and monitoring of lupus nephritis. Once a diagnosis of SLE is made, patients should be screened approximately every 3 months for lupus nephritis, assuming that the patient doesn't already have it. Screening includes a urinalysis, which looks for protein in the urine called proteinuria, as well as blood cells and cellular debris, all possible signs of lupus nephritis. Other tests include certain autoantibodies, assessments of renal function, and vital signs. Once a diagnosis of lupus nephritis is suspected, the amount of urine in the protein is quantified, either by a 24-hour collection or a spot urine protein to creatinine ratio. The next step is a renal biopsy, which helps confirm the disease as well as provides additional information to help the clinician in deciding therapy. Finally, once treatments are started, monitoring of urine proteinuria occurs more frequently until the patient achieves a renal response. Once that happens, continued vigilance is necessary, as many times these patients relapse, sometimes even years later. Now that I've walked you through what lupus nephritis is, how it can affect patients with lupus, and how we diagnose and monitor it, I'm now going to next explore the importance of achieving what we call a renal response to therapy. Renal response is generally defined by the amount of proteinuria reduction seen at a given time point. Reduction in proteinuria has been demonstrated repeatedly as the single most important metric which predicts long-term renal outcomes in patients with lupus nephritis. In the studies shown here, patients achieving a renal response at 1 year to treatment were less likely to end up on dialysis 10 years later. As depicted on the left side of the graph, of those who had a complete renal response or near normal levels of proteinuria, only 8% were on dialysis 10 years later. In contrast, patients who failed to achieve either a complete or even partial response, as shown on the right, 87% of them went on to develop renal failure. This highlights the importance of achieving a renal response to therapy, especially a complete renal response. The hard truth is that renal response rates with traditional first-line treatment regimens are unacceptably low, and thus arguably represent the most important unmet medical need in lupus nephritis. Without going into the specifics of which therapies are used, the principles of treatment involve use of certain immunosuppressive drugs plus steroids. A number of different studies in LN, including the one shown here, have all reproduced very similar endpoints when utilizing these protocols. If you look at the combination of complete and partial responders, hardly ever do you achieve more than a 50 to 55% response rate. That means that nearly half of all lupus nephritis patients will have little to no response to standard of care, reflecting an insufficient treatment paradigm. Published last year, new guidelines for the treatment of lupus nephritis were proposed by our European colleagues. They have set forth new recommendations regarding expectations for response to therapy. By 3 months, patients treated for LN should see a reduction in proteinuria by at least 25%. This is often the first time point that clinicians decide whether or not to alter therapy or not. By 6 months, the target is a 50% reduction in proteinuria, and by month 12, near normalization of urinary protein excretion should be expected. These recommendations, again, highlight the importance of achieving a complete renal response to therapy. In addition, because of several recent studies suggesting that lower doses of steroids may be equally efficacious to high-dose steroid protocols in the treatment of LN, they have recommended lower doses of steroids when treating lupus nephritis. For more aggressive LN subtypes, they recommend pulse IV steroids, but then followed by nearly half of the daily dose of oral steroids that has traditionally been used along with a more rapid taper. For less aggressive lesions, that dose is even lower. The new paradigm in corticosteroid dosing is consistent with the steroid dose protocols that have been used in recent trials conducted by Aurinia. Finally, I would like to share with you some resources developed by Aurinia for the lupus nephritis community. The All-In program, created with the help of people with lupus nephritis, provides information about the signs and symptoms of lupus nephritis, diagnosis and management, and experiences from others living with the condition through resources and personal video testimonials. We invite you to learn more at allinforln.com, where you can join our community and sign up for a lupus nephritis awareness kit. I would like to thank the AAKP Organizing Committee again for inviting me to speak to you today. And we here at Aurinia look forward to being able to help serve patients and families living with lupus nephritis. Thank you.
Thank you for that presentation, Dr. Collins. I have a couple of questions for you. AAKP's membership has expanded rapidly over the past 6 months, with an ever larger group of rare disease, diabetic, and lupus patients and their caregivers. At what point should lupus patients and their caregivers request to see a nephrologist if they're not seeing one already?
So that's a great question. I really think, because I've been a rheumatologist for most of my career, that a relationship for the patient with as many qualified caregivers that are going to be able to help them through this process is going to be a beneficial one. So what I think is that patients should, at the first time they're diagnosed, ask the rheumatologist or nephrologist if the other physician could be a part of that healthcare team to help better the outcomes and increase the odds of having a good outcome. So the short answer is as soon as possible.
Thanks. One last question, Doctor. Looking back to when you began to develop your expertise in this area, are you optimistic that innovations are happening that will help patients in our lifetime?
Absolutely. I came up through the era of the biologics. Prior to some of the medications that are currently used to treat other rheumatic diseases, we really had very few effective therapies. But the past 15 to 20 years has seen a real revolution in our understanding of how to treat these autoimmune diseases. And now it's lupus's time. We've seen over the years a lot of increased understanding of the pathogenesis and really being able to identify targets that have a meaningful clinical impact. And so this is just the beginning, and I think there's going to be a lot of promise in the future for patients living with lupus and lupus nephritis.
Thank you very much, Dr. Collins. Our next panelist is Dr. Jeffrey Perlmutter, President of the Renal Physicians Association and Medical Director of Holy Cross Hospital. Dr. Perlmutter?
Hi, I'm Jeff Perlmutter. I'm a nephrologist who works in Rockville, Maryland, which is very close to Washington, D.C. I would like to thank the organizers of this meeting and the leadership of the AAKP for inviting me to speak on this very important topic. I had the opportunity to attend your annual national patient meeting last year. Found it very interesting and informative, and I'm happy to be a part of it this year. You've asked me to speak about, I think, a very important topic, which is slowing the progression of kidney disease. As part of the Advancing American Kidney Health Initiative, one of the charges was to, in fact, reduce the rate of kidney failure. Within the payment models that were suggested by CMMS and CMMI, one of the quality metrics, interestingly, was the remission of depression. Now, I think remission of depression is very important. However, with respect to what your nephrologist does for you, I think that remission of your kidney disease is much more important and may actually lead to remission of some of the depression that a person might feel when they've learned they've got chronic kidney disease. I'm sitting in my office now, and under normal circumstances during a workday, across from me would be sitting a person who's been referred to me because they've got kidney disease. And the most important thing that person wants to hear from me, what they want to know before they leave my office, is that I do not think that in their lifetime that their kidney disease will get to the point that they will need dialysis or a kidney transplant. And I know many of you in the audience are in that situation, have faced that situation, and that's why slowing the progression of kidney disease and preventing it from getting worse at all is so very important. These are my disclosures. I'm the medical director of a couple of dialysis units. This is what I'm going to cover with you today, how we measure progression. That is, how do you know your kidney disease is getting worse? Various things that you can do to keep it from getting worse, and those are listed there. And that includes modifying some of the things that you do in your lifestyle. How does one know if the kidney function is getting worse? I know many of you know some of this, so forgive my repeating it. I do not know if it's contained in any of the other talks, but the two things that one looks for is a blood test called the serum creatinine, and then a test of the urine where the amount of protein is measured. With respect to the creatinine level in the blood, there's not a specific normal. Down towards 1 is, of course, what one would hope for, and being as high as 10, as many of you know, is not very good. However, whether or not a creatinine is normal is very dependent on the age of a person, the gender of a person, and other factors. One knows that the kidney function is getting worse when the serum creatinine goes up. That is, higher is worse. More recently, the way that we follow kidney disease with respect to the filtering capacity of the kidney is to look at the estimated glomerular filtration rate, or kidney filtration, and that's what that little e means, and that is an estimation. Now, normal is above 59 if you look on a lab report, and that's what it will report. However, what normal is may depend on you as an individual, and just to keep that in mind. And with eGFR, lower is worse. So as the blood creatinine goes up, the eGFR goes down. There have been some controversies about what should be factored into estimating the eGFR, but for the purpose of knowing whether or not one's kidney disease is getting worse, that's not important. Just that creatinine going up is bad, eGFR going down is worse. The other very important thing to know is what is the level of urine protein, either measured as the total protein, and I've given you the name of that test, the PCR, with normal being less than 200, or doing a more specific test called the urine albumin creatinine test, where albumin is essentially egg white protein, and I've given you both the normal, incipient, which means early stage kidney disease, and overt, which means later stage kidney disease. The important thing to know about these values is that in the incipient range, the normal urinalysis will not test positive for protein. It will not do so until the amount of albumin has reached the greater than 300. So measuring the urine albumin can be a much more sensitive indicator of whether or not one has significant protein in the urine. Many of you may be familiar with this, which shows the stages of kidney disease up and down on the left, and the amount of albumin on the right. We call this a heat map because getting worse goes to the hotter colors like red or orange, and better is green. The point here is not to have you memorize this, but I would like you to look at the line across where it says mild to moderately decreased under G3A, where the GFR is 45 to 59. Notice that with normal albumin, there's a low risk, but that the risk as the albumin goes up gets higher and higher. So it's not just the GFR that's important, it's how much protein there is in the urine. The other important thing is that you know what is the cause of your kidney disease. For 70% or more of people who end up going on dialysis, diabetes or hypertension are the number 1 and 2 causes of the chronic kidney disease. However, there can be other diseases that cause kidney problems. I've listed some here, autoimmune diseases such as lupus, certain cancers such as multiple myeloma, multiple other diseases. There are what we call primary kidney diseases that have very, very long names, but affect only the kidney and not other systems in your body. There are genetic diseases. You may be familiar with polycystic kidney disease, and then other diseases that are linked to specific genes. One that's been very much note lately is ApoL1, which indicates risk of getting worse for African Americans with chronic kidney disease. And there are a variety of other genetic disorders. Most of these do not yet have any specific therapies, so it's unclear whether testing for these genes is important. Polycystic kidney disease does have a specific drug therapy that is available, and that would be important to know if that's the condition that you have. The other thing is to be sure that there's not urinary tract obstruction, which is a correctable problem. In my practice experience, most of the time where this happens in an unknown fashion are in men who have ignored the fact that their prostate is enlarged and they have trouble urinating, but it can occur in women as well and can be fairly easy diagnosed with a sonogram. The most important thing that anyone with chronic kidney disease should do, regardless of the cause, is to control the blood pressure. The goal for people with chronic kidney disease is lower than for the general population, with the highest that we would like to achieve would be 130/80, and then lower goals depending on the urine protein and whether or not you have diabetes, where the goal might be as low as 120/70 to 75. I will mention individualization more than once. It's very important that your treatment be individualized to what you need as a person and what you can tolerate. Not everybody can tolerate a blood pressure that low, so you try to do the best that you can. There are certain medications that are particularly beneficial, especially in people with increased protein. Many of you may be taking these. One class is called the ACE inhibitors, of which there are 9 available in the United States, and these end in the suffix pril, like losinopril and the other prils. The other class is angiotensin receptor blockers, often called ARBs, of which there are 7, and these end in artan, and losartan is a very commonly used one of these medications. These can be particularly helpful in people who develop a cough with the ACE inhibitors, which is a very common side effect. As I noted above, treatment must be individualized. For example, African Americans without increased urine protein may benefit from a calcium channel blocker rather than an ACE inhibitor or an angiotensin receptor blocker. For people with diabetes, controlling the blood sugar is very important, not only in preventing the complication of kidney disease or the worsening of kidney disease, but other complications such as retinal disease and nerve disease. This is especially important early in the course of diabetic kidney disease, where the protein may fit into that incipient or early stage. When diabetic kidney disease has gotten to the point where there is a great deal of protein in the urine or the estimated GFR has decreased significantly, blood sugar control may not be important to slowing the progression, but remains important with respect to other end organ complications. When a person has gotten to be later in the stage of diabetic kidney disease, it's very important to avoid low blood sugar. This is not specific to preventing the progression, but I thought I would mention it because it's a very deleterious thing for the person and should be avoided. Again, this is why therapy needs to be individualized. There are some medications to treat diabetes that may have particular benefit with respect to kidney disease. One of these are the SGLT2 inhibitors. What these medications do is prevent the kidney from reabsorbing sugar in the urine and can help control the blood sugar that way, but also may prevent the worsening of kidney disease. One in particular, canagliflozin, has a package insert that is an FDA-approved use to prevent the worsening of kidney disease, but there are a couple of others that may do so as well. There are 4 available in total, and these end in the suffix gliflozins. So if you can't remember everything else, you can tell your doctor that you want a gliflozin. Another class of medications which should be used later down the line affects the hormone balance, and I won't go into specifics, but these end in the suffix agglutides. The important thing here is to remember that, again, your treatment must be individualized with people with diabetic kidney disease as well. People with chronic kidney disease, especially later on, can develop an increased acid level in their blood because the kidney is a very important organ in buffering the blood acid and excreting acid out of the system. So a high blood acid is equal to a low blood bicarbonate level, which is essentially baking soda in your blood, which buffers the acid. This is measured as the serum or blood CO2, which is the carbon dioxide level, and is something that people with chronic kidney disease should note on their chemistry panels as you would with your creatinine or your potassium or your phosphorus. Normal is 24. The goal is to keep it 22 or higher, and studies have shown that preventing acidosis can help prevent the progression of kidney disease. Diet may be helpful in this way as well, as I will mention later. The treatment is essentially taking what is lacking, which is baking soda, which can be taken in the form of actual baking soda in the box, bicarbonate pills, or taking a citrate solution. What my patients have told me is that when they try to take baking soda, it's too salty and they can't tolerate it. And the citrate solutions tend not to taste very well. So most of my patients use bicarbonate pills to help avoid worse acidosis. And this is something that one can discuss with the nephrologist. There is an investigational drug called Vivarimer that is an acid binder that's still not available to prescribe. Just as many of you may take a potassium binder to control your potassium, this medication potentially could bind acid and may be very helpful when it becomes available. I mentioned diet before. Two very important things are, number one, avoid high protein diets. If you're interested in weight loss and you have chronic kidney disease, Atkins is not for you. High protein diets will put increased stress on your kidneys, also are high in phosphates and acid, and are not for people with kidney disease. One needs a more balanced weight loss diet. Mediterranean diet may be very appropriate for people. Also, avoid processed foods. One, they're high in salt, and as I note just below this, people who have high blood pressure and many people with chronic kidney disease, high blood pressure, need to be on a low salt diet. Also, processed foods tend to have phosphates as preservatives, as do certain soft drinks such as cola drinks, and they're phosphates that are not bound in the food as would be in vegetable-based protein, and these are not good for people with chronic kidney disease. In general, people with chronic kidney disease should eat a lower protein diet than the usual American diet. I've given you the amount here of 0.8 grams per kilo body weight or less. Americans tend to eat 1 to 1.5 grams in our usual diet, and so therefore you want to be lower than that to reduce the risk of progression of kidney disease. There are those who advocate even eating much lower protein diets, but these need to be done with supervision. Replacing animal-based protein in your diet with vegetable-based protein, such as you might find in beans or other vegetable proteins, may be beneficial. As I noted, animal protein is more acid and vegetable protein is less acid or more alkaline and may help to prevent acidosis. If you want to consider going on a very low protein diet, including with certain special protein supplements, I would recommend very highly that you seek the counsel of a dietitian who can help you avoid some ill health effects of doing so if you're not careful about it. In general, I would say that consulting a dietitian can be very helpful in any case for people with chronic kidney disease. And what I found is that kidney dietitians have become much more available in the community than they had in the past. Perhaps dietitians realized there was a very important need and have moved to fill that need. The coverage with respect to your health insurance should be something that you should check, but it may be very valuable even if it's not covered by insurance. And the last thing is to control your blood cholesterol, your blood lipids, which may require medication. Now, what I've learned from my patients many times is that it is not possible to eat a low salt, low protein, low fat, low carbohydrate diet if you have diabetes. It leaves one with no food and you will starve to death. So again, oftentimes you need to balance things out and reduce things in moderation. As doctors, we take an oath to do no harm. That's called the Hippocratic Oath. Patients need to avoid doing themselves harm as well. Certain medications can be toxic to the kidneys. You're probably familiar with the over-the-counter anti-inflammatories such as ibuprofen, which in small amounts taken infrequently may not cause a problem, but should not be taken in larger amounts and frequently. And I usually tell my patients to avoid these altogether, and I remind them that if they're going for any kind of orthopedic procedure or seeing a rheumatologist, that they need to tell the doctor they have significant chronic kidney disease and should not take these medications. The acetaminophen, which is the brand name Tylenol, can also be problematic for kidneys and should not be taken in excess of more than 2 grams per day. There are many other medications, many of them are prescription, that are too numerous to list, but if you are sure to tell your doctors that you have chronic kidney disease, and even better, if you know your stage of kidney disease, which I'm sure many of you are familiar with and was on that heat map that I indicated, that would be very helpful so that your doctors can avoid prescribing medications that either will be harmful to your kidneys or need to be adjusted in dose if you have chronic kidney disease. Many people have to go for x-ray studies. Some, such as CT scans and others, require the intravenous administration of iodine dye. This can cause a decrease in kidney function that may not reverse. There are some dyes that are safer, and some people with early stage kidney disease don't need to worry as much. But again, it is important to tell the doctor ordering the test and the radiologist that you have chronic kidney disease. And in fact, this happened today. A patient called me this morning and told me that they'd been ordered a CT scan with intravenous contrast. They told me why. I checked their record. Their estimated GFR was 30, so it's not likely to be safe for that person to get the intravenous contrast. I called the ordering doctor. The doctor looked at the reason for why they were doing the test, decided they didn't need to get the IV contrast, and the patient was able to avoid that. Another important thing for people with kidney disease is not to get dehydrated, as this can cause a decrease in your kidney function that, if significant, such as if you have bouts of vomiting or diarrhea, can cause irreversible damage. So if you're in a situation with a GI illness, or in the current situation with COVID, where there can be diarrhea, nausea, and vomiting, it's important to try to stay well hydrated, and if you can't, get help. Beyond a certain point, there's no particular value to flushing your kidneys, and my usual rule of thumb is 6 to 8 8-ounce glasses of water a day, but it's important to remember that fluid intake must be individualized. Some people, especially later with kidney disease, or if you have heart failure, should not drink too much fluid. So again, speak to your nephrologist about how much you should drink if you don't think you're drinking enough. And last is to modify your lifestyle. If anything on this slide is something you're doing or not doing, most important is to stop smoking. Smoking affects your circulation and your blood vessels, including your blood vessels in your kidney, and it's very important to cut back on your smoking or to stop altogether. Oftentimes, transplant programs are not very happy with people who smoke and may not agree to list you if you are a current smoker. Try to get as much exercise as you can. This will improve your circulation, including to your kidney, and help you achieve the last goal, which is to lose weight if you need to do so. During a viral pandemic, it has been very difficult to do exercise and to eat healthy and to get access to healthy foods, but do the best you can when you are able. If you have a great deal of weight to lose, it can be very daunting, and sometimes people just throw up their hands and say, forget about it. What I advise my patients is to go for a little bit at a time. Losing even 10% of your body weight can improve the control of your blood pressure, and if you're diabetic, improve the control of your blood sugar. I discussed at the beginning of this how important it was to work with your nephrologist to slow down the progression of your kidney disease. When I was a kid, there was a commercial where Smokey the Bear told us that only you can prevent forest fires. What I'm telling you today is that only your nephrologist can help you remit kidney disease. I thank you very much for your attention and for the invitation to speak with you. I think we've got a couple of questions that they want me to answer.
Thank you very much, Dr. Perlmutter. And like the others, I have a couple questions for you. First, AAKP and RPA are both aligned on the need for new innovations to detect and treat kidney disease early and to delay kidney failure as long as possible. As the president of RPA, are you optimistic that change is coming and that more lives can be saved in the near future through new diagnostics and biologies?
So I'd like to frame my answer with sort of the arc of my practice experience. And if one disease kind of measures the arc of my medical career, it is that of HIV. I was a third-year medical student in 1981 when I saw my first patient with what turned out to be HIV/AIDS. We did not know what the person had. There was no test for HIV. The person had a pretty typical presentation of HIV/AIDS with diarrhea and weight loss. I remember looking at this person's stool under a microscope for ovin parasites, which was a potential cause of the unexplained diarrhea. Later on that year, this person ended up in the intensive care unit with the kind of pneumonia that people with AIDS used to get, and rarely get now, thank goodness, pneumocystis pneumonia. The first report of the acquired immunodeficiency syndrome actually came out in 1981, sometime between June and September in the New England Journal of Medicine. So that sort of marked the beginning of my medical career. When I was an intern and resident, the hospital where I worked, the most common diagnosed form of pneumonia was pneumocystis pneumonia, which is the pneumonia associated with AIDS. Took care of many people with HIV before there was treatment, before there was even diagnostic tests for it. At that time, it was a terminal disease. As we go forward, 20 to 30 years, HIV is now a chronic disease with people living long lives, people being able to get kidney transplants. Unfortunately, some people do get chronic kidney disease, but they seem to do just as well on dialysis as anybody else does. So if I take that as a measure, that in 20 to 30 years, we can take a fatal disease, a uniformly fatal disease, and turn it into a manageable chronic disease, then of course I've got to be optimistic that we can do the same with kidney disease. Now, unfortunately, things have moved a little bit slower in the kidney disease community. The availability of regular dialysis was in 1973 when it got covered under the Social Security Act with Medicare. And things haven't changed all that much for our regular dialysis patients. So maybe things are going a little bit slower, but your organization has declared this the decade of the kidney. So this is the time to apply the pressure to get things done. There are medications under investigation that have the potential for slowing the progression of kidney disease, regardless of the cause. My organization, the RPA, and me personally, are very willing to partner with you to help prevent this. I've mentioned HIV/AIDS before. When you look at the funding for diseases under the NIH, when I've looked in the past, HIV/AIDS falls at about $3 billion, with funding for kidney disease about a third of that. That's just not acceptable. Kidney disease is the 7th or 9th leading cause of death. I don't remember right now, but we've got to do more and get more funding to help this very, very costly and devastating problem. I tried to look up what the current funding levels were today, but that part of the NIH website wasn't working.
Thanks, Dr. Perlmutter. One more question. AAKP has a long-standing alliance with the Renal Physicians Association, and we work quite closely on legislation and policy issues. Can you tell us, as a physician, what it's like to be on Capitol Hill meeting with elected officials when you're accompanied by a patient advocate like those from AAKP?
Well, first, I would like to say that the RPA treasures our relationship with the AAKP because we understand how important is your voice when it comes to trying to affect change, especially when it comes to regulatory and legislative issues. I learned how to talk to legislators and their aides by going to these visits with patients who really knew what they were doing. They knew how to get at the problem. They knew what the aides or the legislator wanted to hear. What you bring to our Capitol Hill Day is that you have your personal stories. Most of those items that we advocate during our Capitol Hill visits are related to patient care. There are very few issues left with respect to physician compensation. And you being the people who are affected by the laws and the regulations, we understand how important it is when you go in there and you tell the story that illustrates the problem. And then perhaps we finish up with what the legislation actually means. So it is a very valuable part of what we do. And this past year, we had to do it by telephone rather than in person. But the patients who were on the phone with us still had very powerful stories to tell and added greatly to the experience of going on Capitol Hill. And we thank you for that.
Thank you to all of our panelists today for sharing your insights on innovations to diagnosis and disrupt disease progression. We appreciate your time and your expertise. Everyone have a wonderful day. Thank you.